day of the week for sure. Yes, I just said we're better than any other day of the week of VMR. Robbie's not going to concur. He's too political to say that, but I am not. What we would like is for someone to volunteer to present a case. Remember, we're really friendly, and any case that has been on your mind, we would love for you to volunteer to present. Robbie is fueling up right now with that peanut butter bagel toast, but Nutella.
Figured it out, man. You're a one-man show today, Prof. Rez. You're a one-man show.
How are you, Robbie? Don't aspirate on us.
I'm doing really, really well. I had a very nice 5.5 mile run with this guy.
Wow.
Nutella and peanut butter. And is sitting here pretending to be an angel when he's not at all. He was so bad on the run today, full of not so nice energy. So
it looks like he's sunbathing.
He doesn't he? Look at him. Look at him. Look at him. He's just like, I'm gonna just sit here and tan next to you.
Wait, what do you mean he wasn't behaving? What was he doing?
Oh, don't even get me started. He kept running after all these other dogs and he got in the way of this like older person who was trying to run, and he almost tripped her, and she got really mad at me. Yeah, it was a very it was supposed to be a relaxing run, but it wasn't at all.
Well, listen, hopefully we're gonna relax you with a great case.
100%.
Once again, who has a case? We do have a backup case, but I would rather not do the backup case because it's through Human DX. We want you to present your own case. You know, that would be ideal. So out of 30 people, no one with the case. That's right, Hans. Total silence. All right. If really no one has a case that they want to share, we're gonna have the incredible Yaz take the mic.
Hello, everyone. Yeah, I have a backup case today, and it's something that I really enjoy trying to do in the app. But again, shall we start? I don't know who's scribing. Okay. So this is a case of a 77-year-old male presenting with altered mental status. Should I keep going? Okay. So he was brought for the patient's spouse. The patient was minimally verbalizing and refusing medications this morning. He was anxious, taking off his shirt, which is unlike him. The day prior, he was more interactive and taking his medications as usual. There is more history to this. Should I keep going? Okay. So about 4 weeks prior to admission, the patient developed altered mental status. He couldn't speak or swallow and was having tremors. He was found to have a complicated UTI due to fluoroquinolone-resistant E. coli, which was treated with IV ceftriaxone. He has more history, like it's a long HPI. So about 3 months prior to admission, the patient's baseline mentation, he was able to fully converse and perform every single neuro test, but he had noticeably changed per the patient's spouse. Like his mental health was progressively declined. And prior to this, at that time, he was diagnosed with a displaced fracture of his right second metatarsal bone, which was managed non-operatively. So I can help Maddie scribe to it because it's a lot. Should I keep going?
Yeah, this is a great story, and I think I'm glad you kept going because it shows us how complicated the story is. And
yeah. This patient, this 3 months previous since his fracture, he had been bedbound, and then he started being less interactive, does not converse with full sentences, but he was brought because he started having a behavioral change.
Yeah, I think you've given us a lot of data to begin to reflect, and I'll just share some 10,000-foot view thoughts and ask Professor to reflect on that and share any other details that come to mind. I think this goes to show you, this goes to show you how when you're trying to solve altered mental status and you're tracking your thoughts, if you just hold on to what you thought initially and then how that changed over the course of the subsequent aliquot, it goes to show you that when the time course evolves, your thinking evolves significantly. So you really need to know the time course of the disease to solve altered mental status. But the time course can help you make an even more important distinction independent of the diagnosis. So if somebody is chronically confused, they definitely have a brain problem. If somebody is acutely confused, they often don't have a brain problem. Acute altered mental status we solve using MIST mnemonic, M for metabolic, I for infection, S for structural, and T for toxin. And if you look at all those 4 letters, 3 out of the 4, M, I, and T, are all extrinsic things. M for metabolic, I for extracranial infection, and T for toxin, which means that 3 out of the 4 cases, at least, or categories of acute altered mental status are extrinsic to the brain that poison or affect the brain. In stark contrast, patients with chronic altered mental status have 100% chance of having an intrinsic brain problem. So here, the time course is really intriguing because we're getting a subacute dimension with maybe an acute component. And so the key question is, what is the base rate of subacute altered mental status? Is it like acute, where M, I, and T are extrinsic? Or is it like chronic, where it's almost 100% in the brain? And the answer, it's kind of in the middle. Subacute altered mental status is the hardest disease category to solve because it spans a whole variety of unusual presentations of common illnesses. So it could be that this patient has had subacute hyponatremia or a subacute urinary tract infection, which has been complicated by an abscess, or a rare presentation, a classic presentation of a rare disease. So that's why subacute AMS keeps me on my toes, because I both have to be wide awake to just something very common presenting in an unusual manner, or something very, very rare, but presenting in a very typical disease state. And that's why this case has my attention, because it's very easy to make a base rate based mistake and ignore the common causes. And it's very easy also for many people to ignore the possibility of something rare here simply because the UTI and the ceftriaxone are in the mix. So those are the 10,000-foot view thoughts. Prof. Rez, I'll hand the mic to you.
All right, let me take you to the 10-foot view thoughts. You know, Robbie, a few years ago, we were at a institution, and that one patient had a tremor, which we neglected to focus on. And I don't know even if we got the DX right, but what was the diagnosis in that case? Do you remember?
How could I ever forget? And I really hope I'm right. Hyperthyroidism.
You are right. And so all I'm saying is that the tremor is something unique. Oftentimes we don't hear that in the HPI. And so it may or may not be a signal to the final diagnosis, but honestly, the fact that it's mentioned and that it was concerning to the patient's family makes me really prioritize that in the clinical syndrome. So this is not just subacute confusion, but this is subacute confusion with tremor and other neurologic findings that seem to involve the brain. So what I want to show you really quickly is this approach to tremor, and it'll be very brief here. And then from there, the physical exam will be most helpful. So are you guys seeing the screen for tremor? And Aaron Berkowitz, he was jealous of the MIST mnemonic for medicine. And so he created the NMIST, which includes primary neurologic disorders, metabolic stuff, structural toxins. But really, Robbie, what I'm doing here is I would, at this juncture, and especially after the physical exam, prioritize the DDX around the tremor. I'm assuming that this isn't someone that has a known history of an essential tremor, which is the most common form of tremor. But I will be studying that tremor closely. And this is just the lay of the land, which we'll dive into deeper based on the physical exam. Take a screenshot off because this is exclusive content on a paywall. All right, back to you. Yes.
Great. So now for the past medical history, it's a little bit interesting with this patient. He had a chronic subdural hematoma complicated by seizure disorder, and he has been on anti-epileptic drugs for 2 years with no breakthrough seizures. He has a chronic deep venous thrombosis with IVZ filter, internal venous cava, I guess. He has benign prostatic hyperplasia. CKD is stage 4 with a baseline creatinine of 1.6 to 1.8. He has previous past medical history of gout, hypertension, and MGUS. Now for his, he also had a total hip arthroplasty, total knee arthroplasty, uretary calculi lithotripsy, right femoral and iliac vein angioplasty, and thrombectomy. Now for his family medical history, his father had cardiovascular disease and the mother had Parkinson's disease. For medications, which are quite a lot, warfarin, lacosamide, carbamazepine, temsulosine, bivigron, febuxostat, lisinopril, simvastatin. He does not smoke. He does not take alcohol or any recreational drugs. And that's it for his past medical history.
Yeah, I'll be very brief here and interested to see if Robbie has anything to add. But really at this juncture, everything is just speculation. Like you have this very complicated past medical history, but don't let that throw you off the main problem you're trying to solve, which is someone with subacute progressive confusion. And even you can qualify the confusion. It's not someone who is having slowed movements or has apathy and lack of interest that you might expect in Parkinsonism with the mass faces. This person is acting anxious. It's almost like a hyperactive subacute confusion that's progressive in nature. So you look at each of these, and what I do is I look at the seizure disorder and anti-epileptic medication, and I ask myself a few questions, like, could this be a manifestation of a seizure because they're subtherapeutic on the anti-epileptic? Unlikely with the way that the altered mental status is described. Could this be a consequence of the anti-epileptic medication? Because we know that anti-epileptic medications can lead to cerebellar ataxia. I'm sure they can lead to neurocognitive dysfunction, and they can lead to tremor. So I'm tracking that and thinking, could this be a side effect of a medication in the context of CKD? With regard to the DVT, all I do with that is ask myself, was there a impetus for this patient to develop a clot? And is that same driver of clot causing the altered mental status? And usually when you think about an impetus for clot, I'm not talking about so much immobility and surgery or trauma, more so in terms of hypercoagulability. So this would make me want to potentially get an MRI of the brain, and it would have to be diffuse clots to cause something like this. The MGUS, it's not unusual. You just track it to make sure they don't develop into myeloma. Again, I don't want to go too crazy with this aliquot. Like, I think we need the physical exam. Is just the way I would summarize this is a person who's hyperactive, subacute, progressive confusion with CKD on anti-epileptic medications, and we have to get the physical exam. Robbie, anything to add there?
Not at all. I think that's absolutely superb. It's like basically we're saying that this patient has now 1 bajillion reasons they could be altered, but that's almost counterintuitively not helpful because it just goes to show you how at risk he is. But we've proven that these are nothing but risk factors. We just have to prove maybe some of them are actually causing a problem. It was This week's, I don't actually want to ruin it. Did you read, Prophet? Did you read last week's NAGM case?
No, I haven't.
Okay,
Don't ruin it. But I have a case for you on RLR, which again, it's just like this. And if
Yeah.
you put, and yeah, anyways, I don't want to ruin it for you, but it's such a humbling case.
Yeah, I think that there was a theme in that case. I won't tell you anything about ruining for you, which is telling you that the patient had so many risk factors for the disease that he had. He had a syndrome, and he had all the risk factors for that syndrome. But it turns out the diagnosis had nothing to do with those risk factors. So risk factors are just risk factors. They don't prove that the patient has a disease from that risk. The patient could have a disease from a completely independent entity. So just because we have so many highways to altered mental status for this patient does not mean the patient drove on those roads. It could be completely separate entity. And the more highways that the patient has, the more confusing it gets, because you're like, well, it could have gone on this one, could have gone on this one, could have gone on this one. So why would you just hold on to all those possibilities? Just try to study the actual syndrome and figure out where the patient came from.
I really love that. It's like almost like we're trying to crystallize our problem representation before giving a DDX in someone with a very complicated past medical.
All right, Yaz, the mic is yours, my friend.
Okay, so for physical exam, vital signs, temperature was 36.5, heart rate 83, respiratory rate 16, blood pressure 141/62. He was oxygen saturation 100 on I guess it is respiratory aid. And room air, sorry. I'm getting used to the abbreviations. Now for general, he is alert, oriented to name only, but in no acute distress. For head, he's normocephalic, extraocular movement intact, the pupils are equal, round, reactive to light and accommodation, no scleral icterus or conjunctival injection, no nystagmus, and he has dry mucous membranes. The neck is supple, there is no nuchal rigidity, no cervical lymphadenopathy. His cardiovascular, it's normal as 1:2, no murmurs, scallops or rubs. In extremities, there is no cyanosis, clopping, or pedal edema, but there is rigidity in both upper extremities and lower extremities. For neurologic, the cranial nerves are grossly intact when the patient follows command. There are no gross motor deficits. The strength is 5 out of 5 in bilateral upper extremity, large muscle grips, 3 out of 5 in bilateral lower extremity, large muscle grips. The sensation is grossly intact through light touch. We are unable to elicit DTRs or perform cerebellar testing due to a lack of patient participation. Babinski's equivocal bilaterally, myoclonus noted in bilateral lower extremities. Psychiatric, he has a flat effect, minimally verbalizes, and there's intermittently follow commands. And this is for our physical examination.
Yes, I think this exam is incredibly helpful, as Prof. suspected it would be. And I think the two things that we're found are the presence of movement abnormalities, which is rigidity and myoclonus. And now I think it's curious whether the patient truly had a tremor or whether the tremor was a colloquial term to describe more specific movement abnormalities like myoclonus and rigidity. And so I think the key question is, well, what does this do for us? And I think at the simple level, it helps us prioritize an intrinsic brain issue. And I think with rigidity, there are localizations of rigidity within the muscle. There are localizations of a rigidity mimicker, namely spasticity in the spinal cord. However, the vast majority of rigidity, especially in the context of encephalopathy, localizes to the basal ganglia. So for me, I'm starting to wonder now what basal ganglia disorder this could be. And just because the disorder is in the basal ganglia does not mean it originated there. There still could be a variety of paraneoplastic conditions, medication effects, or toxins, but they are specifically targeting what appears to be the basal ganglia based on their rigidity. So I think that's the general progress I'd make with that term. I'll pass the mic to Prof. to reflect on the myoclonus or other thoughts, since he honed in on the tremor from moment -5.
I think it was like such a great point you made, Robbie, that could the tremor that was initially described just be myoclonus? I think that was brilliant. And really with myoclonus, there's one form of myoclonus that's totally normal. You all experience it. Maybe you can put it in the chat what that is. What form of myoclonus do we all experience, which is normal? As far as like the DDX for that, that's like a very unique finding, honestly, in myoclonus. And there's a few diseases that it makes me really prioritize when I hear myoclonus. In the context of someone on an SSRI or some kind of antidepressant medication, it really prompts me to consider diagnoses like serotonin syndrome and the neuroleptic malignant syndrome as well. That's with rigidity. But in someone with dementia, if you say dementia plus myoclonus, I always think about Creutzfeldt-Jakob disease, which can have a sporadic onset. And so dementia so now I'm using different symptoms that are most concerning to the patient to try to make progress on that differential diagnosis. But I'm left a bit tempered by the fact that I know myoclonus is most often due to a metabolic, toxin, or medication-related process. Once again, anti-epileptic medications not only cause tremor, but they can cause myoclonus. Of course, those are more a diagnosis of exclusion, unless you have supratherapeutic levels, I think. I would have to study that. I'm not as familiar. But really, Robbie, where my mind is the N-MIST mnemonic. Is there a primary neurodegenerative disorder like Creutzfeldt-Jakob disease or, dementia with Lewy body? Or is it a medication like the patient's anti-epileptic medications? Or is it something structural, within the proper brain? So where do we go next with this? With this exam, honestly, in addition to the basic labs, you really want to get that MRI of the brain and the spine. And if that is unrevealing, and we don't think this is related to anti-epileptic medication, the next step would be an LP to consider the diagnosis of Creutzfeldt-Jakob disease. Oh, and by the way, all of you experience jerky movements when you're falling asleep. That's myoclonus. When you sleep, right? You're like sleeping in class or at an airport, and then you kick out your leg. I bet you Nor right now is just kicking out his leg, thinking that Robbie was verbally abusive to him today on today's run. Dogs have myoclonus, right, Robbie? Am I right?
Oh my God, yes. He knows you're talking about him. I don't know if you can see him. He said his name, he goes, yes, they do. And they also bark in their sleep, which is absolutely amazing. He'll in the middle of like being sound asleep. So he'll have myoclonus and he'll bark at the same time. It's kind of amazing. Yes, please keep going. By the way, I was going to say you either fall asleep in your favorite Friday RLR VMR, but it was too late to say that, but I still said it anyway. Yes, tell us more, please.
Of course. Now for the labs. White blood cells, 7.4, hemoglobin, 11.3, hematocrit, 32.2, platelets, 233. The sodium, 145, potassium, 4.1, chloride, 108, BUN, 17, creatinine, 1.79, glucose, 102, AST, 19, ALT, 25, total bilirubin, 0.3, outfus, 97, INR, 2.1. We have urinalysis, which had trace blood detected with 0 to 2 RBCs on microscopy, otherwise normal. Troponin less than 0.01, TSH 0.5, vitamin 12 was normal, ethanol level was normal, We also have treponema antibody negative as well as SARS-CoV negative. And we also have ECG, a CT head without contrast, MRI, and urine toxicology. Should I keep going with those ones?
Actually, before you give those answers, maybe I can just do a quick screen share and then give it to Robbie to comment on the labs. Anything else he otherwise wants to. What I really want to show all of you is like the power of the schema. And are you guys seeing the myoclonus schema here? Yeah, this was actually created with Aaron Berkowitz. And you see the power of including the base rate, but literally what I'm doing right now is I'm looking at the whiteboard and I'm going through this differential diagnosis. So we got no hit for metabolic. There's really no evidence of infection. Right now, we have the possibility of a medication side effect like anti-epileptic. Then you have still structural stuff that we haven't ruled out because we don't have the MRI just yet. And then you have your primary neurologic disorders that are still, we've pretty much, I mean, you could still have Hashimoto's encephalopathy because you need a TPO antibody. It's not just based on the TSH, but you still have primary neurologic disorder at play here, potentially structural and potentially toxin. Robbie, as I have this screen on, anything else that you want to reflect on right here on this?
It's out, nada. Yeah. Do you want to pull up the labs real quick, guys? Yeah, I think, honestly, if you look at the labs, I think what they do for me fundamentally is they just emphasize the notion that the problem is more and more likely to be in the brain. There's no abnormality with the CBC. There's no abnormality with the basic labs. And so I think that that's what we're doing is it intrinsic or extrinsic, intrinsic or extrinsic? And I think the probability of intrinsic disease rises only because you haven't found anything else outside. Yeah. Other thoughts, Prof. Rez? Okay, alrighty, yes, tell us more.
And so maybe, Robbie, that makes even like the medication less likely with the duration and the symptomatology. Maybe we even remove that and just focus on primary neurologic disorder, like a neurodegenerative process versus something structural. Agree? Yeah.
The one caveat would be unless the patient's getting ceftriaxone continuously, I've seen that just like cefepime cause this. So that's one thing that I was going to ask Yaz at some point is, was the ceftriaxone a few days for UTI or is the patient still on it?
It says that it was the 4 weeks and that's it. It didn't continue.
Okay, that's a long time to get ceftriaxone. So especially in a patient with CKD, we talk a lot about cefepime-induced neurotoxicity, which can happen in patients with CKD, but I learned from a case in Japan, actually, that ceftriaxone can do the exact same. So I think now that it's been stopped and the patient's not getting better, I think it would be a stretch to pin it on it. But just know that as a fun fact is we talk about cefepime a lot, but the carbapenems and ceftriaxone have been described to do the exact same thing that cefepime does.
But and that, I think through analogic reasoning would make me say, like, if that antibiotic can do it, why can't an anti-epileptic do it? Yeah. So I think then we include still primary neurologic, structural, and medication side effect.
All right, yes, tell us more.
So for the EKG, there is a sinus rhythm with intraventricular conduction delay. It was found that he had a left bundle branch block with a QRS duration of 160 milliseconds, QTC 434 milliseconds. For the CT head without contrast, the ventricles and sulci are prominent. There is a chronic lacunar infarct within the right basal ganglia, but no acute intracranial hemorrhage, midline shift, mass effect, or depressed calvarial fracture. The MRI brain without contrast, there is a chronic microvascular ischemic changes, but no acute abnormalities. Should I reveal the urine toxicology?
Oh, why should you not?
Okay, so it was negative for drugs of abuse. The serum acetaminophen and salicylate level were normal, but they found the diagnosis. Should I say it?
Oh, no. Oh my gosh. Oh yeah, you're so funny. Thank you for not spilling the beans. Yeah, Prof. Rez, I think that it's interesting with the CT head that we essentially prove that the patient is at risk for did you get it? No? Yeah, we proved that the patient is at risk for basal, like now you have an explanation for some things, right? You have a severe vascular disease to the point where your patient has an overt infarction in the right basal ganglia. And so the tension would be, I think, in real life is to know how long is that infarct. And I think on MRI, you're able to time that infarct, and the infarct is chronic. And so I think what this says to me is that the patient is at risk for developing vascular dementia, and the movement disorder equivalent for that vascular dementia, which is that the patient has vascular Parkinsonism, a form of Parkinsonism, one of the most common forms of Parkinsonism that occurs in patients with recurrent infarcts. So I think the key question is that you look at the imaging and you say, it's all things that are chronic. Why is this patient decompensating before us? And I think that's an important exercise. Of course, my mind is probably a little bit biased by the fact that Yaz told us there's more coming. And so I might have been prone to making the mistake without that nudge that this is the answer. But I think if you're honest with it, you're like, all these things are subacute to chronic. Why is the patient syndrome continuing to evolve? But they do explain, for me at least, a vascular dementia phenotype, especially in a patient who is so prone to, as Prof. Rez suggested early on, clotting. But why he's getting worse, I think, is a question that still probably should be answered.
I love that, Robbie. And, if you had framed this case as rigidity and tremor, then it would have activated the Parkinsonism frame. And within that frame, you have the neurodegenerative causes, like obviously Parkinson's disease and then Parkinson plus, but then you have the secondary causes. And as you mentioned, it's not only the metabolic, the infectious, but also cerebrovascular disease. So I think you have a really good explanation of this rigidity and tremor, and then the anti-epileptic drug can add to that. So why does it have to be one diagnosis? Why can't it be multiple hits that are causing the manifestation of the patient's symptoms? Meaning the anti-epileptics maybe make you more vulnerable to another insult causing Parkinsonism. The part that I'm having a little difficulty with is just the continued confusion. I guess if that MRI showed a lot of disease, or like I would have to speak with the radiologist. Like I'm trying to do a law of proportionality here with regard to the vascular pathology and the fact that this patient is just progressively getting worse. I'm really interested to hear from Yaz as to how it was ultimately reconciled.
Yeah, so should I reveal what they found? Okay, so for this drug screen, they found a supratherapeutic carbamazepine level of 16.5 UG per milliliter, which normally should be from 4 to 12. And in addition to his elevated QRS duration, the patient was diagnosed with mild to moderate carbamazepine toxicity. So they kept they discontinued carbamazepine. They initiated telemetry to monitor for ventricular dysrhythmias with IV sodium bicarbonate to be given until the QRS was less than 110 milliseconds, and checking serial carbamazepine levels every 4 hours to assess for the serum peak levels. Although the patient did not meet the criteria for GI contamination, and for the next 3 days, the levels normalized and the signs and symptoms subsided.
Yes, thank you so much. I think that it just shows you the power of a schema. Like literally, like when you have a very thoughtful person like Aaron, who has seen a lot of neurology, create a schema, usually the answer's within the schema. And I think in this case, Robbie called out like a basal ganglia lesion early on. I really think it's a dual hit as opposed to one diagnose. I would love to hear your thoughts, Robbie, on that.
Rafaz, I completely agree. I don't know how much of this patient, how much you expect him to improve. If I were to guess, I know Yas probably doesn't have that information because it's human DX case. If I were to guess, I bet his encephalopathy improves. Like you said, what's this confusion? But I don't see the movement abnormalities. I don't see the rigidity getting much better. Maybe the myoclonus and the altered mental status gets better. And I completely agree with you. I think he probably has two things. It's cool though, in retrospect, to reflect on data that I missed, which is the subtle clue in the EKG. So carbamazepine toxicity is manifested as a sodium channel blocker. And so that sodium channel blocker acts just like a TCA by prolonging the QRS. So that's a really cool clue in retrospect. It's easy to ignore it in real life because who doesn't have at 72 with so much vascular disease, who doesn't have interventricular conduction delay? But it is a clue, and it is probably the reason you would give sodium bicarb and titrate the sodium bicarb until the QRS narrows. So I never thought that the EKG would be a clue to altered mental status, but this is a very nice example of how it might be. Yas, do you have any more info on that or thoughts on that or anything from the case itself?
Yes, actually, the doctors were actually like thinking that it was other. That's why they did all the screening, and then they did a toxicology screen. But apparently, carbamazepine, it can present with neurologic symptoms, cardiac and anticholinergic, and it has a wide range. That's what is so difficult to point it, and that's why it's a diagnosis of exclusion. Neurologic symptoms can be from AMS to agitation, drowsiness, nystagmus, ataxia, dysmetria, myoclonus, or hypertonia, or even seizures. And anticholinergic syndromes, we'll know them, and also cardiac symptoms, which can include tachycardia, hypertension, or dysrhythmias. And they keep talking, the doctor kept talking about the teaching pearls of how to treat, and following an overdose, the levels can take even more than 96 hours to peak. So that's why they kept checking 4 to 6 hours until there was a definite downward trend. And that's basically it, because they did not do a relationship between if it had been his chronic kidney disease or if any other drugs he was taking could have been the reason for this high titration.
Such an educational case, yes. I've actually never thought or read about carbamazepine toxicity, and I'm really excited to take that opportunity and dive deep into that. Thank you so much. Anything that when you were doing this case, Yas, that you wanted to emphasize, or things that we didn't get a chance to teach, or points before we pass the mic to Bia to teach?
Yeah, actually, I am very thankful for this discussion, because while I was doing it, I definitely thought like maybe this is a metabolic issue. This is that, like, I anchored myself, which I find myself doing that a lot, and thinking, well, maybe this is an also like structural lesion because this patient had a lot of past medical history. But yeah, like I am really thankful for the chat and your discussion. And yeah, that's why I wanted to share with you.
You're too kind. Thank you for having a case. And I hope all of you are inspired to have a case to present. I think we'll learn a lot from them. And I think you do too when you put it out here and have other people think about it too. So thank you, Yas. I'll pass the mic to Bia for teaching points.
Hi, of course. Thank you very much for this precious case. And so it was overall a case of a patient that was presenting altered mental status. And we understood that it is essential to look at the time course. So in particular, to see whether it's chronic, acute, or subacute. And if the altered mental status is chronic, we may think of an intrinsic brain problem. If it's acute, we know the mnemonics, metabolic, infection, and structure and toxin that can help and guide us. But in our case, it was a subacute progressive AMS. So we then analyzed the confusion that may come with hyperactivity or apathy. And we overall discussed also the concept of movement disorders, and that may come in the form of rigidity, myoclonus, and tremor. rigidity makes us think more of a localization to the basal ganglia, not necessarily starting there. It could have also been a paraneoplastic lesion or a toxin moving to the basal ganglia. The myoclonus makes us think of primary neurological disorders, metabolic or infectious or structural problems, but also toxic and mad side effects. And in particular, when we saw no abnormalities in the lab, we were starting to think there was something in the brain, maybe intrinsic or extrinsic. However, the length of the infarct seen at the CT and the chronic microvascular systemic changes seen at the MRI and the EKG proved us with a valuable insight of being in front of a carbamazepine toxicity that may present with several signs and symptoms. So altered mental status, nystagmus, ataxia, seizures, anticholinergic syndrome, and tremor. All right. Thank you
that
very
was
much.
incredible. Thank you so much. I think very much to the point, very methodical. Question for you. What's your nationality?
My nationality?
Yes.
Yeah, I'm Italian.
Okay, I was hoping so because I saw Milano, made me think of Milan.
Oh,
You have
yeah,
to be Italian, but let me not assume anything. But since we're on fire today with our diagnosis, I should have assumed that I would be right on this. No, I'm just joking.
yeah, indeed. But fun fact, I've never been to Milan. But I'll be there soon because I need a visa to come to the States. So yeah.
Oh, so where in Italy are you?
Southern Italy.
Oh,
Italy. I was
Sicily?
born in Puglia. Puglia is like the hill, but I moved a lot. Like I've lived in Naples for a while, and I'm studying in Pisa. But right now I'm in France. So yeah, I kind of crazy.
Also, I'm not trying to expose where you live for everyone.
No,
watching this.
What's your address? Yeah.
All right.
Robbie lives in Japan.
All right.
Anyone wants to know?
All right. Yeah. But it's a common question. Like I'm asked very often, like whether I was born in Milan but no, it's just a common surname in Italy. Yeah.
Rafrez, that was her first time doing teaching points. Did you know that?
Yeah, exactly.
Unreal, right?
I'm super
Unreal.
sorry. I'm super sorry. I mean, I've missed so many things, but I've tried to do my best. Thank you for appreciating my work.
It was absolutely incredible. Like I actually was tracking your teaching, like how you were putting it out in real time. You know, it's a predictor of how it will come out. And I think the organization from the get-go was amazing. I feel like the coolest thing that you did there was to actually resist the temptation to put everything down. You were like,
No, I think it was just that we were saying so many things and I couldn't keep up with you
Yeah,
guys.
the trick is to ignore what I say and just focus on Robbie, and it'll be very good.
I don't know, Rashford. I don't know. I think you nailed it.
Thank you very much appreciated. You made my day or week, maybe. Oh,
Enjoy your run, and hopefully you get to watch some Netflix while you run, which is another fun fact.
yeah, no, today I'll think about the case. So I'll listen to music and to my thoughts as well.
Good. All right, y'all. Thank
Thank
you
you guys.
Friday, and see
Thank
you
you guys.